All right, good morning, everybody. We're going to start a little early, a couple minutes early. This is Shaun Sullivan. I'm a physical therapist, athletic trainer, both licensed and certified. I am the managing partner of two renewal clinics, both based in East and Auburn. My topic today is going to be tendinopathy in both the shoulder and hip. The shoulder and hip are very highly related anatomically and neuroanatomy-wise through some fairly common threads. The shoulder is a ball inside of a socket, and the hip is a ball inside of a socket. Both joints are very mobile, very flexible. Both joints are hence somewhat unstable. So they depend on muscular activity and muscular strength and tendon activity to remain stable and remain operating at a high level. So I want to define some terms of tendinopathy. Tendinopathy is kind of the umbrella statement of obviously some kind of pathology of a tendon. Now, remember that a tendon is the connection between muscle and bone. In tendinitis, we talk about an irritation or inflammation, or possibly even some micro tearing in a muscle tendon. So, obviously these can be all over the body. We have tendons everywhere: feet, hip, knee, shoulder, elbows, wrist, etc. When we talk, and these are usually acute, so they're less than 6 months. You're out working in your yard, and you do something kind of funky, and you strain your shoulder, and it's probably an acute tendinitis. Okay, so it's irritated, it's inflamed. Okay, tendinosis, on the other hand, is the chronic portion of tendinitis, usually 4 to 6 months after you've done that something weird in the yard that you injured your shoulder. So the unfortunate thing is that tendinosis is non-inflammatory. And this picture shows us tendinitis on the left, Osis on the right. And you can see the difference of the microfibers and the muscle striations of, on the left, the tendinitis being obviously very inflamed, and the tendinosis not being inflamed at all. So what's happening is that in the tendinosis state, we're getting a chronic, non-inflammatory, and it's degenerative. It's degeneration of the tendon, repetitive strain, chronic tendinitis, no healing time, et cetera, et cetera. So when we talk about, I'm just going to kind of hover over that tendinitis, so you can see that inflamed portion. You can see that portion that was inflamed. Now it's created scar tissue. It's created this non-inflammatory reaction, things like that. So you can see what's kind of happening, and like we talked about, degenerative in nature. So that at the hip, at the shoulder, at the Achilles, at the tennis elbow, things like that, we get this chronic degenerative change in the tendon and the attachment sites. Okay. So Just a little research sentence statement. Research suggests tendinitis is far less common than tendinosis, and tendinosis is often misdiagnosed as tendinitis. Now, that's probably gonna be a little bit controversial, and I'm gonna say some other controversial things too in a minute here. So that we're thinking that, these chronic issues at 4 to 6 months with those small micro tears, degenerative in nature. So it's really tendinosis and not tendinitis. And again, it goes back to that non-inflammatory reaction, and that's going to be important to a couple of things that I say next. Pain is mostly from nerve transmission or chemical irritants. So now it's not necessarily inflammation, which we've already said in the tendinosis state is non-inflammatory. So it's not coming from the inflammation. It's usually coming from the nerve, the chemical irritants, or the fact that the lymphatic system, hey, there's that lymphatic system that I talked about before. That lymphatic system has kind of shut down and it is not operating smoothly. And so we've got all this bad waste products and again, scar tissue and all these things kind of hanging on that tendon. And that is creating the pain. Okay, so now into a little anatomy. Okay, shoulder-wise, we have to really think about that we have at least 17 muscles that are attached to our shoulder blade, our scapula. Now, I just talked about the fact that our shoulder is very mobile and hence it's very unstable. Okay, it is probably the most unstable joint in our body, but it is the most flexible. Okay, you can't have one without the other, or you can't have both. So in the shoulder, when we talk about rotator cuff, and pretty much, shoulder tendinitis or tendinosis usually involves at least one of the rotator cuff muscles. Now, where I'm at right there is the supraspinatus, and then infraspinatus, teres minor, teres major, subscapularis is on the front side. I don't have I guess my next picture, I have a decent picture of that. But the idea is that probably, I'm gonna throw out a number there, probably 90% of the shoulder issues that I see link back to supraspinatus. Supraspinatus is not very well vascularized, and especially after we're like 25 years old, it actually starts to decay and degenerate at its attachment point so that it becomes very vulnerable. So it is kind of easy to strain it, tear it, disrupt it, however you want to call it. Okay. So, and okay, I'm gonna roll that down. So this is subscapularis on the front side. And you can see all the attachments and the points of interest in our shoulder. We have bursa, I haven't seen this term a lot lately, but bursitis used to be a very old term that, I've got my shoulder bursitis. Well, it was probably a tendinosis, but whatever. So, and it describes the rotator cuff tendons and muscles. You got the long head of the bicep, you got the short head of the bicep, you got the acromioclavicular joint. All those are areas that can be irritated. All those are areas that can be injured for whatever reason. Most of them, there are inherent weaknesses because of what we went back to of the stability issues or instability issues. This joint is very mobile. So that can be a cause for issues anyway, because it is very mobile and inherently weak at times. So now, hip-wise, when we look at hip, this is the psoas muscle, comes down into the inside of the femur. Iliacus muscle that comes down inside the femur. Hip joint, again, is that ball and socket. Hip joint is actually quite mobile if you were to, if you were to be asleep or under anesthesia. The hip moves quite far, quite far, because it's like a teacup in a saucer. So it rolls around. It's a little bit unstable. The ligaments are obviously a little bit stronger and thicker at the hip joint itself. And then on the back side, we've got gluteus maximus, got piriformis, gluteus medius is under there. The obturator is here. The internal gemella, obturator externus, all these little tiny muscles of the hip that help rotate, and et cetera, et cetera. So again, those are, and in the depiction of muscle to the white is the tendon. So therefore, when we hear about, my hip bursitis is kicked up, well, it may be, but it's probably the fact that that tendon right there of glute max, or the tendon of piriformis, as it attaches to the trochanter, the greater trochanter, has got some degenerative tearing to it and micro tears in it. So it's past the inflammatory state. It's this degenerating, non-inflammatory tendinosis. Okay. So let's see, we already covered hip, gluteus, piriformis, adductor. Oh yeah, adductors come from the pubis down into here. It is a hip stabilizer. It's really a thigh muscle, but it's attached to the pelvis and it's attached to the femur. So, I consider it kind of a hip muscle because it's fairly important. From what I've learned, and I kind of know this, I'm just going to put up the recovery screen. In differentiating between an Itis and an Osis, diagnostic ultrasound is basically the kind of gold standard to determine whether you have a Itis, a tendinitis, or a tendinosis. Okay. And again, it goes back to that highly inflamed versus not inflamed, seeing some of the micro tearing, some of the chronic degeneration. Okay. MRIs are less helpful unless the tendon has calcified, which calcification typically occurs when our body is trying to heal something. It lays down calcium. It lays down bony deposits, and that's, calcific tendinitis, or even we want to call them spurring. That's our body's way of trying to heal something, and it's doing it in that fashion. And that's the way our body operates. So, all right, so we've talked about the anatomy. Now, some of the recovery possibilities. And we're going to get into a little bit of controversy here. So in the acute phase of a tendinitis, we're going to talk 2 to 3 days. You heard something on Saturday. Today's Tuesday. This thing is like, doesn't feel all that great. So the idea is in 2 to 3 days, we got that tendinitis going. Recovery it's possible. The chronic issues and tendinosis, you're looking at sometimes a couple months, sometimes 3 to 6 months. Surgery, if we have to talk about surgery, which, would be our last resort, you're talking about obviously a lot longer than that. Okay, so now specifics. In an itis, a tendinitis kind of thing, rest, non-steroidal, and ice. Those are kind of our 3 current thoughts, and they're kind of old school thoughts. Now, I'm going to throw some controversy in there. A non-steroidal is arresting the inflammatory process, at least partially. Now, we need the inflammatory process to heal. The inflammatory process is necessary because of cleaning out the waste products, the lymphatic system doing its job. That's all part of inflammation. Removing the waste products, removing all the junk, okay? So, when this is so common when somebody says, oh, I hurt myself, I threw down 2 Motrins and I put some ice on. Okay. Those are all things that we've been taught. I've been taught for 35 years. I'm going to say that there's some of the controversy is that the anti-inflammatories, we need that inflammatory process to start the healing process. So, and then the ice, ice actually slows the circulation and can create nerve damage. So, do we really want to throw a bunch of ice on something and make it frozen and slow down that circulatory system that is trying to move the waste products and help the healing process? Okay, so, and I'm sure at the end, I know there's going to be a couple of question and answers or questions about that, and we'll talk about it. In a tendinosis, remember, no inflammation. So we start talking about stretching and strengthening. Now, one of the new things that has been brought up with tendinosis is PRP, protein-rich platelet injections. I think there's enough research now out there that they're showing benefits. A couple of years ago, it was kind of hit or miss. I think they're getting stronger with the research now that we've got some time of doing those injections. Okay. So, and when we talk stretch and strengthen, it's basically stretch and strengthen. Work on load, work on movement. A lot of these issues. I have that. A lot of these, that's right there in front of me. Our joint mobility, especially of when we talk about hip and shoulder, we have to talk about joint mobility of the joint itself plus the surrounding joints. We talk about the clavicle, the collarbone in a shoulder. We talk about the scapula. We have to talk about thoracic spine. We have to talk about cervical spine. If the mobility is restricted at any of those places, it's going to affect the shoulder. So that what happens is we get compensatory patterns because something is happening at the thoracic spine that's affecting the shoulder blade that then affects the tendon function and muscle function. So strength, obviously strength loss. Let's face it, Saturday you're out doing yard work or something and you injure your shoulder and you think you're 19 years old again and you're actually in your 50s like I am, it's not the same. You don't have the same strength, and you don't have the same mobility. So, there's one good preventative measure that I know was a question. One good preventative measure is to be smarter and, take what you got, rest, don't do silly things like, hoisting bricks over your head that weigh way too much or whatever. Okay. Nutrition has a big portion too. If we're dehydrated, we talked about this in the lymphatic portion of a webinar. If we're dehydrated, if we've got poor nutrition, definitely affects muscle and tendon function and joint function. Okay. So one thing that kind of all of us have noted in this last year is that all of us, a lot of us are sitting more. We're working from home. We're sitting more, we're working from home, we're less active, we're not getting outside, we're not exercising, things like that, for a multitude of reasons. Stress is higher. Again, poor nutrition, poor hydration, things like that. These all have far-reaching effects on the things that we've been talking about, tendinitis and tendinosis. And those are my observations, and I have clinician friends that we're all seeing kind of the same things: more joint restrictions, weakness, less lymphatic flow. We're not circulating well. Shoulder and hip issues are becoming more prominent. If you're sitting at a laptop at home in a bad setup, you're firing up some carpal tunnel issues, you're firing up some issues at the shoulder, impingement, neck pain, things like that. You're sitting more, so you're sitting on your butt, you're cutting off the lymph flow and the blood flow to your lower extremities. The hip is now flexed. It's kind of what we've become in the last year, and it's kind of disturbing. But there are ways to mitigate those situations. And I think that's one of the next webinars that we need to do is something like that. Is these preventative measures for people that are sitting at home, working from home in bad situations and bad posture, and et cetera, et cetera. So back to recovery, we reduce the activity, the aggravating activity, okay? Either change the load of an exercise program or the mechanics of an exercise program. There are certainly ways that exercise is good if it's not done poorly. If we're doing exercise in really poor mechanics and poor posture and just really overdoing things, you're asking for issues. You're asking for a tendinitis. You're asking for a tendinosis. You're asking for some kind of injury. So that is not a good thing. Back to all the sitting and things like that, we want to adjust our ergonomics, adjust our posture, and our mechanics. Is that what's creating the issues? We have to really be honest with ourselves, with those kind of things, to kind of figure that out. What is the aggravating issue? Is it too much sitting? Is it, we're sitting on a couch doing laptop work, and your head is down, your shoulders forward, all those kind of things. We can support some of these things with a splint, with some people will do some kind of a thumb spica or something for a hand, for a carpal tunnel kind of thing. Is it a matter of like with a shoulder? Do you put it in a sling for a moment? I don't know, possibly. Ice. We just talked about ice being a little bit controversial in terms of, do we want to stick ice on something for 30 minutes. I try to compare it to this past February. Take your hand, you're driving around town, take your arm and stick it outside your window for 30 minutes as you're driving around. Is that really something you want to do with ice? Is to make it that cold, that uncomfortable, that we're causing damage. Okay. And there's where I say, let's heat it up mildly. Raise the dynamic temperature, raise the circulation a little bit to flush the system instead of slowing the system down so much that we're getting that lessening of the inflammatory reaction. Not that and when I say this, I'm saying it with, we're not trying to we're trying to heat something. We're not trying to do it for an hour. We're not trying to burn it. We might be doing it for 8-10 minutes tops. And then we do some movement, and then we go back and kind of let things chill a little bit. 8 or 10 minutes. We're not doing 20 minutes. We're not doing 30 minutes. We're not doing 45 minutes. Okay. Things like that. Massage. Again, back to the circulation. Moving waste products, moving that inflammation. We have to get it to move so that we get good blood flow in, good lymph flow in, things like that to help us. Nutrition and hydration. If you're dehydrated, probably nothing's really going to heal. And that kind of goes for everything. If we're dehydrated, you're fighting a losing battle. Okay. I talk to so many patients that they drink, they're like, well, I have 1 bottle of water a day. Okay. That's dehydrated. That is definitely toughening up your tissues. That is making your tissues very inflexible, very not very movable, not very healthy, to be honest. We talk about strength, eccentric strength. Eccentric strength is the quote unquote negative portion of a contraction, so that we are, let's say in the shoulder, we are lowering something against gravity, and we're kind of fighting that lowering, or at the hip, we're fighting the gluteus medius or maximus function. We are lowering something, so that we're not raising it, we're lowering it. Okay, these are really beneficial in like the Achilles tendonitis, tendinosis kind of situations, plantar fasciitis situations, where we're doing a negative contraction, negative portion of the strengthening, so that we're getting it's kind of a more efficient contraction. I like to use a lot of isometrics. We've been doing more isometric work with Achilles, plantar fasciitis, shoulder things, and I don't know that we really have a great explanation of why it helps, but it does kick in some neural control. It does move the fluid a little easier. And it's a muscle memory thing. So isometrics definitely work. For a long time, I kind of like, why am I even using isometrics? But in the last few years, it's like I've read more and learned more, and it's like isometrics help. So that's a thing. And isometric is a non-moving joint. So you're basically doing muscle contraction without joint movement. Okay. So we can do it on the shoulder. We can do it pretty much anywhere, because it's just an isometric contraction. It's not a moving contraction. Okay. And then we have to adjust the load in terms of, we have to adjust the load of an exercise program if that's what has created this. Do we need to decrease the resistance, increase the repetitions? shoot for more endurance versus more strength and power. Those are all kind of things. And to be honest, these are things that we as physical therapists understand hopefully a great deal and are able to help with those kind of things. Sometimes, a lot of these issues can be created by so-called personal trainers, strength and conditioning people that maybe don't have quite the background and education that we as physical therapists do. So there's my pitch. If you're in a situation where you're at a gym or whatever, and you've got some personal trainer, strength and conditioning kind of person, and they have pushed too far in the wrong direction, you might want to find yourself a good physical therapist that can get you back on the path to recovery. Because you keep doing bad mechanics with bad joint restrictions and bad muscle function, you're going to have lasting problems. Okay. So, Kate, do we have any questions that I didn't address?
I had to step away for just a minute. Did you already cover the massage therapist question or not yet? No? So somebody asked, they've been seeing a massage therapist for their shoulder and hip. They said they get relief for about a week, but then the discomfort and the aches come back. So they're wondering if they should ask their doctor for a PT evaluation.
Of course they should. I just went over the
Could you maybe explain some of the differences between what a massage therapist might do?
I just talked about personal trainers and strength and conditioning people in a gym situation where they're doing things kind of not in focus and not well educated or whatever. So it'll go, I'm going to take that right back to massage therapy kind of person. They have their space. The fact that you're getting some relief, that's cool. The fact that it's not lasting, that's not cool. We as physical therapists are going to evaluate, you say shoulder. Well, I just talked about, is it a neck problem? Is it a thoracic spine problem that's really causing your shoulder issues? We're going to try to address multiple angles to improve the function of your shoulder by looking at joints above and below that are affecting that shoulder in particular. So, of course, you should see a physical therapist.
Great. She just added that those issues started when she was doing CrossFit. So that definitely makes me think that there might be some ways you could help as a PT. We did have one other question. We did have one other question, which I know you went over a little bit, but somebody was asking if there's any other prevention tips for tendinopathy that you would recommend generally.
Right. Obviously, the best prevention would be to not get one. To do things, if things are nice and clean, in terms of, let's say, a shoulder, that you've got really good motion, and you start with an appropriate exercise program, an appropriate load, and just kind of like avoid all these things, great. Maybe you have a job that is requiring like super duper repetition, and it's kind of almost unavoidable. There's some prevention things in terms of strengthening. We talked about nutrition, we talked about hydration, trying to some of the work environments are really tough in terms of if you're doing high repetition. Even, we talked about the sitting thing and doing computer work. It's like you can get all kinds of issues just with sitting, and it's not really even load thing. It's more of the repetition, and it's the, do we have to change our posture often? Yes. Do we have to move often? Yes. So prevention wise, sometimes prevention is the key of just kind of staying out of trouble and trying to work through, some of these things, especially the high repetition things. I don't know how to change that, because that's, if it's your job and your job depends on moving A to B 800 times in a 10-hour shift, it's like, ooh, you want to be strong. You need to be strong. And that's where that strength comes in. Things like that. So.
Great. Thanks, Shaun. Thanks so much for sharing. That was a lot of great information. I do just want to let everybody know that the people who registered for the webinar will be receiving a follow-up email that has a recording of the webinar. It'll also have Shaun's contact information and some summary information as well. So yeah, go ahead, Shaun, if you want to talk about our locations, and then we can wrap up.
On my screen, where to go? On my screen, I've got our 16 locations. Like I said, I'm at Bay City East, managing partner at Bay City East in Auburn. Let's see, questions, and then thank you.
All right. Thanks, everybody, for joining us. And thanks again, Shaun.